So welcome everyone, and thank you for joining today's Aderek Pala third quarterly meeting. It's very, very exciting. For those of you joining us for the first time, so Aderek Pala, the acronym stands for Ichut Chaim Derech Rafua Palliativit Lo-Onkologiית. And it's a new community practice that we started way back in November in the conference in order to promote non-malignant palliative care in Israel. And so we do have a WhatsApp group, and we're doing these quarterly meetings in order to promote this and study from one another and learn. So today's session, Navigating Uncertainty, Communication in Non-Malignant Palliative Care, will focus on how we approach complex clinical conversations in the context of serious illnesses, where prognosis and trajectory are often less predictable, and we struggle with that. So it's my pleasure to introduce our amazing panel of speakers who will be presenting here today. So we're very honored to have with us Dr. Leah Steinberg. She is a family physician and palliative care lead at Mount Sinai Hospital in Toronto, Canada, whom I've been very privileged to work with. Also an assistant professor in the Division of Palliative Care in the University of Toronto. Dr. Steinberg has a clinical and academic focus on communication and serious illnesses. She's developed numerous national courses and training programs, including the ABC's Communication Skill course. And joining her are our very own Dr. Merido, Director of the Palliative Care Unit, and Dr. Nmrod Khan, Senior Physician in the unit, both specialist in internal medicine and palliative care from the Saraski Tel Aviv Medical Center, which is Ichilov. So thank you both and three of you, for being here, and I'll hand it over to our speakers.
Thank you, Asya.
Yeah, hi everyone. So thank you for having us, and it's a great discussion topic. We thought to do it through a case presentation of a patient with a severe heart failure, and if I'm looking at the presentation, I cannot see no one. All right. So maybe Leah will start with the introduction. Actually, why
Sure.
a palliative, why a different approach is maybe necessary for non-oncological patients.
Sure. Thanks so much, Nimrod. And thank you, everybody. And thank you for such a warm welcome, Asya. It's an absolute pleasure and privilege to be here speaking to you. I want to start with just this acknowledgement that the world of palliative care in non-oncologic disease is really a growing, developing creation that's many people around the world are trying to figure out, and there are some important reasons, I think, that we have to rethink or at least push ourselves a little bit to change the way we think about palliative care in the non-malignant world. And I think when we think about the world of palliative care, both academically and clinically, it really grew up in the oncologic world with a very clear set of parameters. The major difference, of course, between one significant difference is really the trajectory of illness is so different. And when we thought about palliative care in the oncology world, although the initial trajectory can be up and down, really the key difference is that at the very end, and there's a slide in a little while, but just to sort of set the tone, there's a really steep curve at the end with most oncological illnesses that really looks very, very different than the non-malignant illnesses. At the very end, in the last, we're pretty aware of the last 3 to 6 months in oncology that people have a fairly steep downward trajectory. And they don't really have significant recoveries from that. And that is how we sort of really created a lot of work around palliative care in terms of prognosticating and in terms of also resources that people were able to access, because it was quite clear when somebody was on that final trajectory. And in the non-oncologic world, there are so many differences. One of them is this fluctuating trajectory, where people can get quite unwell, require invasive ventilation, non-invasive ventilation, be seemingly very close to end of life, and then turn right back around and really be able to return home in many situations. They may not reach the same baseline that they were previously. However, they really can have quite a significant change, improvement, and that is confusing. It's confusing for clinicians, it's confusing for patients, it's confusing for families, and that makes this sort of where does palliative care enter really challenging. Another big difference is the prognostication, of course, is impossible in many non-malignant illnesses. In heart failure, it's absolutely impossible. And we try to fit people into these molds of the oncology world. And that really doesn't work for folks. The recommendations from all of the cardiovascular societies really now is to focus on needs, not prognosis, not numbers. And also the low awareness amongst patients and their caregivers and their families of the terminal nature of these advanced serious illnesses that are non-malignant is really, really low. So most people, when they get diagnosed with cancer, have an immediate thought about death and dying, and they realize that this is a terminal illness and their goal is to fight against it, whereas I would say most people who are diagnosed with COPD or heart failure have no idea, not only that it's a terminal illness or potentially a terminal illness, that really it's even a serious illness. So these are really start us off in very different places when we're taking care of this population.
If I may add, even the medical teams themselves, many times they don't have this prognostic awareness, and they treat automatically the heart failure patients and the COPD patients, etc. Even very with very advanced and severe disease, without the maybe the without having in conscious that it might be we might be close to end of life, and maybe we should start prepare and think about the approach.
So really what what we need to think about, I think, and there's many other people on this call who do this work as well, is that we, particularly in hospital, we tend to see our involvement in palliative care and sort of crisis, pain management, go in and sort of sort out, the symptoms and the prognosis and help people transition to more end of life comfort-based approach. Whereas in the non-malignant population, although that's sometimes the case, it's much more of I would say a relationship building, trust building, education-based relationship. Of course, there's symptom management, and of course, there's all the other things that we do in terms of psychosocial support and home-based support. But really, it's about helping people who have had often an illness for many, many years sort of catch up to where they actually are in an illness trajectory. Not particularly, of course, a numbers-based prognosis, but to understand the sort of trajectory. What we would say in medicine is the natural history. We never talk about that with patients, right? Patient illness education is always about self-management, which is great, but it isn't about kind of what the natural history of the illness is. And so that you can't often go in a very short time, tell patients that, because they don't understand why they wouldn't have been told that over the last 10 years of seeing their clinician. So I find it a slower, more trust relation education-based approach.
Another thing that I want just to clarify, because we use terminologies that is not so broadly used. So when I wrote APC, I meant acute palliative care, which is usually the way we treat traditionally the oncology patients, or which their course of disease is hectic and intensive, and we chase a crisis after a crisis. While in CPC I meant chronic palliative care, which is the most of the non-oncological patients, they go that way. And in oncological patients, it's a lot of time breast cancer or multiple myeloma. It's a chronic course in which you have time to get to know your patient and to make a connection. And it's, well, I think, well, just to clarify the terminology, and we'll talk about it more widely in a short while. So this is the patient that we're going to discuss. Let's call him Chaim. He's a male, 70 years old, and he is diagnosed with severe heart failure. Sorry, I lost it. Just a sec. All right. So so advanced heart failure, as I said, and apart from this, he has other background illnesses, as detailed on the slide. He has cardiovascular and metabolic morbidity, moderate COPD, and mild dementia. From the psychosocial aspect, he's a widower. He lives alone in a second floor apartment in a building without an elevator. He's a father of two. His son, let's call him Rami, and a daughter, Nurit. His son recently returned from the US, where he lived for the past decade, and the daughter lives nearby, and is very supportive of her father. Functionally, he's defined as exhausted, and receives a few hours of weekly assistance from the national insurance. And I will note that his wife passed away a few years ago from pancreatic cancer, and this experience was quite traumatic for him and for his children, with something with the home hospice team that was not beneficial, which now adds a complexity, a psychosocial complexity in terms of palliative communication. So a little bit more about the family dynamics. His daughter, Nurit, as mentioned, lives next door and is very involved. She understands the importance of palliative care, and she wants to focus on relieving her father's suffering. The son, as mentioned, he recently returned from a long stay abroad, and he does not understand why his father is being referred to the palliative care clinic at all. He knows that palliative care means end of life. And for him, his father, he has a heart failure, but is nowhere near his end of life. And the last thing he needs, in his opinion, is to receive opioids, which killed his mother, quote, and caused a widespread crisis in the US. And the third, I don't know how to call it, the third person is the cardiologist, who is an excellent doctor who advocates an approach of life prolongation at all costs. And it does not understand why there is a need, in this case, to discuss advanced directives, or in Hebrew, הוראות מקדימות, or ICD deactivation, etc. All right. So this is the first encounter with the palliative care team, and I think Leah, it's back to you.
Mm-hmm. Sure. So as you can imagine, based on what Nmrod has said, the son is fairly defensive when he hears that the palliative care team is going to be seeing his dad. The patient has his own concerns about what happened with his wife, and one thing that the team starts to do is to reframe and change some of the language around end of life care. And I know that a lot of people I work with, follow Diane Myers, who is the palliative care doctor in the US, and I think has a nice phrase, which I can't give you in Hebrew, but you can, is that that palliative care has changed. I'm actually very explicit with patients and families. You often have to name the fact and name the fear that they equate palliative care with end of life care, and explain that it's changed over the last several years to being able to care for people much, much earlier in their disease trajectory, and to wrap an extra layer of support or an additional layer of support around the patient and their family. So that's really nice language, I find. And sometimes I'll actually even say to people that we were so successful at end of life in relieving suffering and providing support that people much, much earlier felt, why couldn't they have those supports, a long time before end of life? And so that's sort of a way that I might explain it. So I think you have to, in many of these families, and also in oncology situations as well, but more so in the non-malignant, sort of really reframe and be very explicit about your role, that it is complementary to the non-oncologic care, whether that's with cardiology or internal medicine or whoever's managing the non-malignant illness, that it's an additional layer. It's not it's not a handoff or a handover to palliative care. So that's been really, really helpful.
Mm-hmm.
The other thing that in my experience I have found is that, and I sort of was hinting at this before, is that it's often a time, it's a much slower process with building relationship and rapport with the patient, because you're starting with somebody who doesn't even realize that they have an illness that could be terminal. They don't have they don't realize they have a life-threatening illness. Their families don't recognize it, let alone the clinician. But and so you're often starting with basically education, building support, trust, and then moving on. But again, you're going to move on with them. It can't be about your own agenda, that you have these outcomes that you must meet, because that can be quite frightening for patients. And so you want to be able to work with them. And my experience is that people have lots of questions and do want to think about the future, but I tend to wait until that comes up more naturally for them, rather than imposing that on them. Or one of the sort of pearls or things that I have found over the years, and has helped, I think, with a lot of conversation, is we'll first talk about this trajectory. So this image here on the right, it actually comes from a cardiologist in the US, Sarah Goodland, who really started writing about this in the let's say in the 90s. She was really one of the first cardiologists who recognized the terminal nature of heart failure and recognized the trajectory that leads to end of life. And this typical trajectory here has people, initially presenting quite unwell, and then having sometimes a very long, unpredictable amount of time back to baseline. That's why these lines here, this can be years. And then there will be this sort of second half of the illness that's marked with these decompensations that can be quite severe. And you see over time, again, sort of a loss of function. Colleagues in cardiology talk about in the years in their clinic, they'll see people, walking in, and then they'll start to come in with a walker. And then, the next year they're coming in a wheelchair. And the cardiologists that I started working with would talk about feeling this lack of ability to care for people, not really knowing what to do, but only having their clinic as the option. So that was something that was really quite powerful, was to recognize that we could add in the extra layer that understood about home supports and home care. In any case, you can see that, right? I like to have people kind of do a little thought experiment where imagine a 70-year-old patient with widely metastatic ovarian cancer who's has ascites and pleural effusions and anorexia cachexia syndrome and is in bed 85% of the time, down here, say, there's almost no circumstance where she's going to suddenly turn around and get better again in a way that the heart failure patient's going to get better. So that's really a dramatic difference. One of the things that I've learned from other people, none of this is anything I've come up with, is to draw, when you're meeting people, maybe the second, third time, is to draw this trajectory for them, to teach them the natural history of heart failure. And a cardiologist I work with actually personalizes it. She actually literally puts the years and the admissions. I don't do that, but and the recognition on the family's part, the patient and the family's part, is really powerful because they often think that there's something they're doing wrong. They don't realize that this is the normal trajectory. And so I'll draw it on paper for them and just talk about how you'll have, these decompensations where you're quite unwell, and then they'll be able to add a new pacemaker or adapt the pacemaker or maybe do a procedure or, get.
We seem to be having a bit of difficulty with Leah. Let me text her as well just to see what's up. But let me ask the audience, in the meantime, any questions about what was introduced now? It's kind of like the baseline of everything that's challenging in communication with these patients, not specifically heart failure, but non-malignant patients who struggle with this trajectory and kind of this uncertainty. I'd love to hear from you, your experience with this. Oh, Leah texted me, lost connection. Yeah. Okay. So she'll resume shortly. But any personal experience that you would like to share?
Sorry about that.
Oh. Carry
on.
Okay, we got that. I was just asking the audience about their personal experience, but maybe not yet. Okay. Leah, just see we're cut off on the last few sentences. But I think we can move forward with this patient.
For sure.
Nmrod, yeah.
Okay, so we're approaching the opioid conflict. So the patient, Chaim, as expected, develops a dyspnea crisis. They try to treat him at home, but they can't do it, so they bring him to the hospital. And he's being admitted. He has an acute exacerbation of both or neither or COPD and CHF. And they start treating him, and the internal medicine team actually calls the palliative care for a consult, which is nice. So the palliative team arrives and talks to the patient, and they decide to treat him. They recommend treating him with low-dose opioids for the shortness of breath. The rationale, of course, is for us is fairly straightforward. The opioids can reduce both the subjective sensation of dyspnea, and decrease the workload of breathing. And it's it's very common as an evidence-based for dyspnea crisis and for shortness of breath, both in CHF and COPD. And I think with Nmrod and Shirley also discussed it in the previous two encounters ago. And of course, as expected, Rami and the family reaction, they strongly object, especially the son. He talks about the opioid crisis in the US, and he worries about addiction, and he worries about death, that he will hasten death, and respiratory suppression. And he speaks about this, and now we approach how to resolve the opioid conflict. So I think the first thing we do is targeted psychoeducation. And when I say psychoeducation, and maybe in general in these patients, I think the education is both for the family, the patient and the family, and also for the caregivers and the teams. Because a lot of the discussions that we have with the teams is mainly the same. So when Leah spoke before and she said, I showed the trajectory to the patient and the family, and I drew the trajectory and I showed them where they are at the trajectory and what's the discussion about what's coming up next. The same thing needs to be done with the patient, the physicians as well. And we see it a lot. So I think the first phase is psychoeducation. Explain why physiologically the mechanism of opioids can reduce the shortness of breath and help with the dyspnea. In terms of the patient and family, of course, use more of a non-medical jargon, but explain why can it help, and also explain the physicians as well. It's part of what we do. Last week, I was teaching in Barzilai Hospital, actually, and medical residents from different wards, and we were talking about dyspnea. And they were pretty amazed that we're talking about low-dose opioids for dyspnea management, unrelated to the treatment with Fusid or with steroids for COPD exacerbations or for bronchodilators, but just prescribing low-dose opioids for a dyspnea crisis. They were pretty surprised by it. And some of them asked, as Rami here, the son asks, wouldn't it cause respiratory depression? So it's very important for us to explain that respiratory depression is very, very rare. And when we see it, it's usually after we see the level of consciousness going down, and it's only with higher doses and with elevating the doses really fast. And it will not happen if we'll offer control and monitoring. I'm jumping to the third part. And do it when the patient is hospitalized and we see it, and it's very low doses, that we monitor this and see that it reduces the shortness of breath and the dyspnea, but it still doesn't have any side effects. Okay? So I think these are the two things that we need to start discussing when we discuss with the family and the patient, and also with the teams. And I think the second part is realigning the goals. And you said earlier that Nurit, the daughter, is very focused on preventing suffering. So we talk about the prevention of suffering and what we can do for the prevention of suffering. And of course, there are non-pharmacologic treatments as well. We're not talking about it here, but in terms of pharmacologic treatments for the dyspnea, this is the mainstay of treatment. And it can reduce the suffering of Chaim, especially when most of the suffering comes from the dyspnea. So you can, next slide. So one thing that helps us is to use, when we talk about with the patient's son and the daughter, is to align the goals. Okay, so we talk about that we have the same goal, which is lowering the suffering. And this is the main pharmacologic intervention that we offer to do it. And we also alleviate the fear from it. We can also discuss addiction, which is really, really
uncommon.
Uncommon, yeah, especially in this setting. But we can also discuss it with the son. So this is the first thing that we do. Oh, sorry, I lost you. Is to talk to them and to alleviate the fear from the medications.
Mm-hmm. I'm not sure if maybe I missed it, but there's also we can give them a sense of control over the situation, especially when the patient is hospitalized and is under supervision and monitored, and we can offer some kind of direct communication with us in case they are worried that something is off. So it's another layer of support and confidence that we can offer, which first may help us to tackle this type of difficulties, and also to strengthen the personal connection and the trust between us, especially if there's gonna be another deterioration in the future. Right. So as we all feared, so after the previous exacerbation, and the patient maybe recovered and returned to his home, and maybe in overall close to baseline functional status. However, shortly after, there is another significant exacerbation, and he is rushed to the hospital again, and now there is a critical decision-making crossroad with complex questions, and I'm passing it over again to you, Leah, to talk about
Terrific.
major.
Thank you. And I'll go in as long as you guys can hear me, and hopefully I'm moved somewhere else, so hopefully I can keep some connection. Asya, can you hear me okay?
Yeah, I can hear you.
It's quite delayed on my end.
Yeah, you want to maybe turn off your camera, maybe it'll help, so we can just hear you.
Okay, great. I'm going to, I think, close my video because I think it'll give me better.
Yeah.
And one of the, questions again comes up is, what is the treatment options for this person? What are the, options for recovery? What is the, what is the conversation? It's a very complicated conversation. And again, the communication here is around uncertainty in a much more in a much more uncertain way than in an oncologic illness. Even if there's no prior documentation, which I do think is really challenging in all populations, you have to find a place of comfort with working with clinical uncertainty, and also hopefully.
We're talking about difficult conversation because the main thing that making this conversation of decision making so complex is the notion that we are really uncertain, or we cannot be certain, or in which direction it is the situation is going. Because when we are treating oncological patients, so we know that there might be an imaging that tells us that the disease has advanced, and there isn't any other treatment line, and it helps us to make a decision and to explain it to the patient, to his family, and to the other medical teams. But in this situation, we're not sure. We're not sure whether if we intubate this patient or do a CPR, maybe we'll recover. You know, we can never be sure, like 100%. So this is the main reason why it is such a complex place, not only for the decision making, but also for the difficult conversation with the patient, maybe, and with his family.
Go ahead, Shirley.
Shirley, you were saying.
Leah, hi, how are you? I will present myself. I'm in palliative care in Bellinson and in the community, and I'm come from like Yael and Nmrod for internal medicine, and with Asya and the dear of everybody, we try to promote and do this non-oncologic palliative care, be more broad spectrum here in Israel. And thank you for everything. I wanted to ask two things before you log off. I wanted to ask if the cardiologist or the pulmonologist or every other primary care physician in this place would offer the opioid. Would change anything? Because Yael said very, I think very precisely that we have to teach the physician first, so they will not afraid from giving opioid to their patient, because I think the barrier is much more with the physician. It happened with the population because morphine equals death, okay? But I think it comes from the physician, because I think if my pulmonologist would offer me a medication that I think it can increase my life expectancy and will benefit my איכות חיים, quality of life, I would have taken it. What do you think about it? If it will come from the primary doctors?
Like the cardiologist.
Yeah.
I think that's an interesting question. I haven't thought about it quite that way, because generally it's really variable. There are some specialists who have recognized that it's a helpful treatment in and of itself, and they are more comfortable offering it. But really, for the most part, I would say they're not. They would see that as our role. So I think I wouldn't worry about individual issues necessarily worry about individual issues like the morphine or the whatever medication. It's, to me, and I'm so sorry I lost internet connection, but to me, the big work to be done is building the trust and rapport with the referring clinician, so that when they are working with the patient, when they're recommending palliative care as their added layer of support, they're basically saying, I trust whatever they say. And so that if the patient goes back and says, they're thinking, that I should be on this low dose of an opioid, they say, absolutely, I totally agree. I don't think I think the bigger challenge another way to think about it is much more broadly building the rapport. If the referring physician is actually going to refer, then I think the important thing is to build the trust so that they support your work with the patient in the moment. Now, one of the things that we've done here in Toronto and in our institution is we actually see patients together. It particularly helps the cardiologists who are not sure what we do and why we're there exactly. I mean, there's already buy-in though. Like the buy-in starts very slowly and has to build over time. but there's enough buy-in that we actually see patients with the cardiologist, and they're starting to see that you have to train them that we're not just going to throw opioids at people because that's what we do. They're going to start to see how patients coming back are looking forward to seeing us.
You see together the admit patient or in the clinic, the ambulatory, the admit patient?
No, in the clinic. In the clinic. So when in the clinic, we see patients in the same clinic. We go to the heart failure clinic so that we're in a constant building relationship with the cardiologist. And they can see, we can say to them, like there's a lot of trust to be built. And so we'll say to them, we're thinking of starting this, and if they don't want to, we won't, because then that's just going to give mixed messages to the patient. So really, I think it's finding the specialist who does come with some understanding or is willing to go for it. And then they start to see that the patients are responding really well, and they tell their colleagues, hey, you know what? This person that I was really struggling with because the son was so angry, because it's actually going way better. It's built that way where I was talking to our cardiologist and their nurse practitioner just the other day, and the nurse practitioner was saying how much easier it's been for this one particular patient because they've built such rapport with the palliative care team. Anyway, I could talk about this too long. So I wouldn't worry about individual treatments. I would worry and think about building the rapport so that the cardiologist sees you as part of the team too.
I think, but this is what Shirley is trying to say, because I think Leah, you're we're privileged and much more advanced than us. I think you already have a relationship with the cardiologist and they trust you, and I think you've done it over time.
Yeah, it started 13 years ago with one cardiologist. So it does take time, and you sort of have to find, in some ways, one option is sort of find somebody who you can build rapport with. You don't have to build rapport with all of them. You can start with one.
Yeah. So I think this is the challenge that Shirley is talking about. But
for sure,
I agree. Yeah.
One of the things we've done in other institutions is we've actually presented to cardiology rounds. We've had a cardiologist and a palliative care doctor present. We've been to various cities in Canada to do this. So that's another option, is to reach out to cardiology and see if they want to have a rounds where where you talk about, and then we can have a Canadian cardiologist who's works a lot with palliative care. We've done that in a few cities where there was a lot of resistance.
It's a good idea.
Yeah, we have something parallel with the pulmonologists. Actually, today, my colleague called me with a patient in his clinic, 89-year-old woman with asthma, severe asthma, and also spinal stenosis, and he wanted to consult because the pain clinic gave her buprenorphine 5 micrograms per hour, and he was concerned that it might cause her, it might exacerbate her breathing or her asthma situation. So, so it's an example we worked together for a while, and we learned to know each other, and then we consult, and afterwards he will feel confident treating his patients with opioids, etc., and vice versa. So I think it's, like you said, it's a relationship that is built over time, which makes all the treatment much more beneficial for the patient.
It's really hard to do this work knowing what you feel like you have to offer and hitting resistance. It's really, really hard. And so I think you have to give yourself permission to recognize that it's going to take some time and that you won't be able to fix the people whose primary physicians are not going to let you in, and just sort of take a breath and find other ways, either through clinicians that are comfortable or thinking about, trying to get their rounds, into their rounds. There was another question in the chat. Asya, do you want me to?
Yeah.
Okay. Adir asked a really good question. And I have a pretty standard answer to things, and that's it depends. There's really no one answer. Let me just go back to the question. I can't get back to it, oddly enough.
Yeah, so I can read it.
Great, thanks.
Adir asked, there seem to be different conversations to be had with different family members. Do you have these conversations separately or with the family as a whole? How, if at all, is the cardiologist involved in these conversations?
Yeah, that's a great question. So it depends. My sense from this case is that the concerns and the issues are so different that probably I would be having both separate conversations and conversations together. But the son particularly, I mean, the daughter is fine, and so to me, I would probably be trying to do a lot of active listening to the son, like a lot of active listening. I wouldn't expect to be able to change his mind very quickly or easily, if at all. And so we're really in a kind of what I think of as sort of the conflict resolution / mediation role, which really is listening. So until the son feels like he's been heard, that he has been able to express all of his worries, and really, really listen, then he may be able to have some listening back to what you propose. And so it's probably, many listening conversations with him, probably having a conversation with him and his sister while he's still so opposed will not be terribly productive. And always helpful if you can have not always, sometimes it's less helpful, but if you feel like, to me, if you feel like people are close, then bringing everybody into the room can be really, really helpful. I find though, if people are really still opposed, the more people in the room, it can just get out of control, or you lose the listening, and somebody's going to start lecturing, kind of like I'm doing now, and lose the listening, and that's never a good thing.
Okay, should we kind of like close the loop about the ICD, and then we can open for short discussions?
Awesome.
All right.
Yeah. So the ICD is a challenge, and we wanted to bring this up in part to talk about we've sort of talked a little bit though already about when you're in conflict with the cardiologist or the specialist themselves, that can happen. And around the ICD, in this case, the cardiologist doesn't sort of appreciate the issues with the ICD. And just to sort of catch everybody up, the issue with the ICD, of course, is that if the person's approaching end of life and experiences shocks from the ICD, that's painful and a very difficult end of life. Now, of course, this always starts with what the patient's goals and treatment preferences are here. So if the patient expresses a desire for end of life that's not involving attempts to have defibrillation, attempts to have resuscitation, then the ICD really needs to be deactivated. And I think that's quite clear. The issue is, of course, if the cardiologist doesn't even agree to approach this with the patient. So I think that's.
Yeah. We agreed it's not it's unusual that the cardiologist will be reluctant to deactivate the ICD, and we used it as a trigger for a conflict that might for any conflict that might take place. As we talked before, between maybe the palliative care and the clinician that is treating the basic disease. Yeah.
I'm wondering if all this conversation will have take place before things would have happened. Like when you insult the ICD, you will ask the patient if you will get, because in Australia I think they do it, or in Canada I think they do it, if you will get very, very sick and the ICD will be will make you suffering, but do you want to activate it? Yes, no, and that will be documented, and
Yeah,
that will be helpful.
So that's a great point. I think so. It depends where in Canada. In Ontario, where we're from, you can't document decisions like that in advance. You can write them down, but they're actually not there's no such thing as advance directive here. And so it would always be a conversation at the time, which I'm a big supporter of, but that's a whole other session. I think the key here is the first thing you mentioned, which is conversations early and as an education / I like the word preparing tool, so that and this is what I was getting at when I lost internet connection, I think it would be ideal if people had the education throughout so that when they were in crisis and really would benefit from an ICD deactivation, it's not a surprise. I think that's the biggest outcome we can look forward to, is that they say, okay, I knew that there was a time. We've talked about it. I knew there was a time, because then they've got the prior knowledge, the prior conversations when they're not in crisis, but then at the time there's a clinical reality that they can come into their decision. And because I think they can't necessarily know 10 years in advance when they're getting their ICD whether or not they would like to deactivate it. They have no idea what that's going to be like. But if you combine ongoing conversations and education with the clinical context and the time, I think you'll get much better decision making. So that's sort of, again, the same thing around the trajectory. It doesn't matter to me if they want to continue getting active treatment. That's fine. Their decisions are their decisions, as long as it's informed. And so the best time to inform people is not in a crisis. So I think that brings up sort of the three takeaways here, that patience is the strategy, not just with our patients and their families, but with our referring clinicians, because it's going to take time. And again, you don't want to push on resistance. That just breeds more resistance. So take your time. Continuous education, which we've talked a lot about. And also now think about that with your colleagues as well. So can you introduce to your cardiology colleagues some palliative education somehow, and the partnerships, of course. I'll stop there.
Right. Asya, you want to conclude?
Yeah, thank you. Thank you so much.
Brilliant.
For even though technical difficulties, we got everything in. We have your wisdom, Leah, and your experience. So thank you so much. And Nmrod and Yael for facilitating this conversation. Unfortunately, we don't have much time, so we can continue discussions on our WhatsApp group for Aderut Pella, and people can reach out to me or to Adir or Shirley. We can all connect you to our WhatsApp group. Yeah, and for our next topic, that would be June 28th. So mark your calendars. That would be about end-stage renal disease. So very, very interesting things to come. So thank you again, and see you next time.
Thank you.
Thank you.
Thank you, Leah. Thank you, Nmrod. Yeah, it was a great presentation.
Thanks for having me. Again, I'm sorry.
Oh, and I see if people are still on. I see Daphne's comment. Thank you for a great talk. I want to put a plug for the clinical frailty scale to help people understand where they are and how things have changed over time. I show them I used to be a 1 and now I am a 2.
I love that, Daphne. I'm going to check that out right away.
I think we should have a separate meeting about frailty as a topic in itself, for sure.
Definitely.
Yeah. All right.
Thank you, Asya, for everything.
Thank you.
Everyone.